Welcome, everyone. Hi, my name is Hanny Al-Samkari. I'm a classical hematologist and clinical investigator at Massachusetts General Hospital and Harvard Medical School in Boston. One of my areas that I focus in is immune thrombocytopenia. This is a really interesting area right now with a lot of newer drugs in the pipeline, a lot of new data, a recent ASH plenary presentation. So we're all very excited about the ITP space right now. It's my pleasure to be here with Dr. Neil Love and discuss ITP. It's very critical when we think about ITP, which is, certainly a morbid disease and can be a fatal disease in very rare instances, that we don't want the treatment to be worse than the disease. This is true at all stages of treatment of ITP. Upfront initial ITP treatment and second line and all the way down to salvage therapy and clinical trials in patients who have refractory disease. So, we have to recognize that corticosteroids are not a benign treatment option, even in relatively short course. This patient, if given high dose dexamethasone, would probably have psychiatric complications from that and could even have that with a sort of 1 mg per kg prednisone taper. Things we have to consider. We have to think about when we're choosing between corticosteroids and IVIG, we really have to think about how quickly we need the response. The patient has some petechiae, but they don't have any sort of substantial life-threatening bleeding. If they did, then we would really want to err toward using IVIG because we're going to get a faster response and improvement of the platelet count 24 to 48 hours with use of IVIG over corticosteroids. Corticosteroids we expect to work within 4 to 7 days. So we can look at the ASH guidelines to help understand, exactly the setting in which patients should be treated and how we can treat them when they present with newly diagnosed ITP. So generally speaking, there are a few platelet count cutoffs, and I say generally because every patient is different, and a patient on anticoagulation for a pre-existing condition requiring that is different than a patient not on anticoagulation. A 23-year-old is different than a 93-year-old, right? So there are obvious considerations that modify these cutoffs that we have here. But if a patient has a platelet count of less than 30,000, generally speaking, they should be treated. If it's more than 30,000, generally speaking, they can be observed unless they're having bleeding symptoms, in which case any bleeding symptom, regardless of platelet count, they should be treated. How about inpatient versus outpatient? If their platelet count is, between 20 and 30, they could probably be treated at home with close monitoring in the clinic. And then one last piece to really highlight is the duration of corticosteroids really should not be longer than 6 weeks if we're talking about a prednisone taper. And if we're doing dexamethasone pulses, we'd want to do up to 3 dexamethasone pulses every 2 weeks. We really would not want to drag on the duration of corticosteroid treatment. That does not help patients go into a remission in ITP, and it just increases toxicities. So the guidelines recommend, pretty much what I had already said. IVIG with steroids when you need a more rapid increase. IVIG or anti-D immune globulin, which we'll talk about briefly if steroids are truly contraindicated, which is rare but does happen. And patients who are pregnant receive either steroids or IVIG. Corticosteroids, as we know, you can choose between dexamethasone or prednisone, or if you're in Europe, prednisolone. There's been a lot of back and forth on this. There have been clinical trials, randomized trials evaluating it. There really is very little difference between these two approaches. Giving dexamethasone does not increase the likelihood of a longer-term remission. There's some thought about this, the lympholytic nature of high-dose steroids early in ITP could have a disease-modifying effect. That is not borne out. The main reason to use dexamethasone over prednisone is because you might get a faster response by about 24 hours. But the downside is obviously that you're giving a very high dose of steroids and therefore putting a patient like this one at risk for having a psychiatric complication. This is something we think about in older adult patients and those patients with history of psychiatric disease. This is from a meta-analysis that really showed really drove home the point that the overall response rate at 6 months was the same between prednisone and dexamethasone, and that it's really, toxicity concerns that we think about when we're choosing between these agents. IVIG, like steroids, has a good response rate in newly diagnosed ITP of about 80 to 90%. We dose IVIG. Generally, patients will get a total of 1 gram per kilogram or 2 grams per kilogram, and that's given over 2 to 4 days. And the purpose of using IVIG is to really provoke a rapid response when that is needed. We cannot forget the toxicities of IVIG. Obviously, it's a very long infusion, and patients often get headaches and infrequently can get aseptic meningitis. Venous thromboembolism is a real complication of IVIG, so it's rare, but it happens, and it's one reason why we don't use this in every single patient that has a newly diagnosed ITP or an ITP exacerbation. And we have to remember that patients with IgA deficiency need to have IgA depleted IVIG, and this is a significant minority of people. It's rare, but it is important to keep this in mind. IVIG is a Band-Aid. It's going to last about 3 to 4 weeks. Steroids will last some duration of weeks or months, depending on the patient's disease, after they're tapered, after they continue, unless the patient is lucky. And in that, about 20% of folks who enter, a durable remission after their first-line therapy. Adults, the vast majority of them, as we know, do have persistent ITP and ultimately chronic ITP. Anti-RHD immune globulin, I mentioned briefly. Typically, we only pull this out when there's IVIG is in shortage, or there's some clear contraindication to giving IVIG. It doesn't work as quickly as IVIG does, but it is a useful drug. The main thing to consider with anti-RHD immune globulin is patient needs to be RHD positive. They need to have their spleen, so it's not useful if the patient's already had a splenectomy for some other reason. And it certainly it causes a hemolytic anemia. This is how it works. It diverts the immune system away from platelet destruction and toward red cell destruction. But rarely patients can have a life-threatening DIC. And this actually got the agent removed from the market for a period of time, and now it's back. But it's just something to remember with this drug. So let's talk about second-line therapies in ITP. So going back to the ASH guidelines, this table, or excuse me, this figure appears in the ASH guidelines. If the patient has persistent ITP, ITP between 3 to 12 months duration, splenectomy really is not something that should be considered, because we don't like to take out people's spleens within the first year. There is a very real spontaneous remission rate within that year, and we like spleens. We want spleens to stay in bodies. For patients that have had disease for longer than a year, so-called chronic ITP, then the potential for splenectomy comes into the picture, along with thrombopoietin receptor agonists and rituximab. These are our sort of standard second-line treatment options. I would add fostamatinib in with this group as well, and we'll talk a little bit more about fostamatinib. But we call these second-line, or I like to call them subsequent line, right? Because we're often going to be going, you try one and maybe it works for a while, then stops working, try another. So, you kind of can cycle through these second line treatment options. And you look at, the bottom part of this, what the patient places a high value on. What is the patient's share? What are their goals? Do they really want to avoid surgery? Do they really want to avoid chronic therapy? And the reason for this is that we don't have randomized data comparing these second line therapy options between one another. And so we have all of these things that are compared against placebo or standard of care, observation, things like this, not each other. So it's difficult to make value judgments pertaining to each of them, and we really have to think about the shared decision-making piece.
Yeah, I just wanted to make a comment about that algorithm, or ask you about that algorithm that you just showed, because what really strikes me, I don't recall seeing many, of course you see a million of them in various places, NCCN guidelines, but what I think is really cool about this, and I'm curious what the background was, is they sort of integrate into the algorithm the patient preference. You know, a lot of times that comes up as a secondary issue. I think I've never seen an algorithm that actually has in the algorithm ask the patient what they think is important. Any thoughts about that?
I agree. I think it is unique, and it's born out of necessity. I think it's a great thing. I think it's something we should do even when we have comparative data. We should be less prescriptivist and paternalistic and more in the shared decision-making space. But in ITP, it's really born out of necessity because we don't have comparative studies like we often do in oncology or, some other areas in hematology. So it really is due to the lack of evidence, but I mean, it's in some ways a positive thing because it does help integrate the patient decision-making.
But I mean, this happens all the time in oncology, just whether to use adjuvant chemotherapy or breast cancer depends on how much they put on toxicity versus, a couple percent. I love the idea of it. I think it's really
Absolutely.
cool.
No, I completely agree. I want to kind of just touch base on splenectomy first, right? So this was previously sort of thought of as the two-thirds cure. Oh, about two-thirds of folks will have a durable response with splenectomy. If you look at this data, it's from decades ago. It's, look at the year of ITP diagnosis on this figure. And these studies are from data from the pre-thrombopoietin receptor agonist era, and in large part the pre-rituximab era as well. So, in the past, when splenectomy was used in the second or third line setting, sort of early in the treatment course, we had the ability to put patients into a durable remission, of course, at the cost of lifetime increase in thromboembolism risk and sepsis and infection risk, things that are all quite relevant. And you still had those third of patients who had no spleen and then had relapse of their ITP, sort of putting them in a worse place than they were before the splenectomy. When we look at more modern data for splenectomy, it's not a two-thirds cure anymore because we're not taking up people's spleens before giving them rituximab and or thrombopoietin receptor agonists. And typically, most folks, unless they really, really don't want to take medication, are cycling through all the medical options before they're going to splenectomy. And that even includes fostamatinib nowadays as well. So what if we look about what's the rate, in patients with ITP who have tried and failed TPO-RA and rituximab? It's less than 50%. So it's less than a coin flip that they will have a response. And some of those patients will lose their response and it won't be durable. So, and this particularly is true in patients who are older adults, age greater than 75, and those who have had more lines of treatment. With most ITP, the more lines of treatment you've had, the less that you've failed, the less likely you are to respond to the next line of treatment. And splenectomy is no different. Rituximab, first of all, rituximab is off-label for ITP. I think important to say that, but it has randomized trial-level data. It has high-level data for its use in ITP, and it's a well-accepted and recognized option. But rituximab is like a longer-term Band-Aid in most patients. If IVIG and anti-D are like a Band-Aid that lasts for about 4 weeks, rituximab is a Band-Aid that lasts on average maybe 18 months. As you can see, about 50 to 60% of patients respond initially, but by 1 year, it's down to less than 40%, and by 5 years, it's about 20%, which really approximates the spontaneous remission rate in ITP without treatment. So, we recognize that rituximab is an option, but it's not it's certainly not a perfect one. And there's also new data that that's come out of the French group that suggests that use of rituximab in ITP actually can modify the patient's immune response and autoimmune response to make it slightly more refractory. So it's something that we think about when we're considering this agent. As far as thrombopoietin receptor agonists in ITP, we have 3 approved agents now. And thrombopoietin receptor agonists have the most data. There's quite a few randomized clinical trials that have been published between all of these drugs, including several global clinical trials. So the highest quality data, the most data. These are all agents that are FDA approved for the treatment of ITP. they do have some important differences, which I'll highlight. So remiplastim is our weekly subcutaneous injection. It's a peptibody, a combination peptide motif conjugated to human IgG1 Fc region. Remiplastim is a very effective drug with a response rate of about 80%, but it's subcutaneous. And in the United States, the vast majority of adults with ITP need to come into the clinic to get this agent. They get their CBC checked based on the platelet count. They're then dosed. So this comes with time commitment and personal costs that are fairly obvious. Eltrombopag was the first oral thrombopoietin receptor agonist to be approved. This drug is convenient for some patients, and obviously that it is oral, but it has some things that you have to consider. One being the food interactions with eltrombopag. When a patient takes a meal with really not a high amount of calcium or magnesium, some of these other divalent cations, eltrombopag absorption drops like a rock. A typical American breakfast, which a lot of people take their medications with, will reduce eltrombopag absorption by about 60%. So patients really need a 4 to 6 hour window around which they're either adhering to very strict dietary requirements, and calcium is in a lot of things, including a lot of vegetables. It's very difficult to avoid calcium and the amount of calcium that will cause reduction in absorption. Or they have to just be fasted for 4 to 6 hours around taking it. Eltrombopag is also associated with hepatotoxicity. About 10 to 11% of patients will develop LFT abnormalities, so this needs to be monitored. It is an iron chelator, which is much more important in pediatric patients as well as women that are menstruating. And so the iron chelation piece certainly can cause iron deficiency in these populations or encourage iron deficiency, which is obviously problematic. High doses of eltrombopag can also change the complexion of the patient's sclerae and skin, and can cause that to look kind of reddish, kind of a muddy looking sclerae. That's rarely seen in the doses used to treat ITP, more with aplastic anemia doses. But in 75 milligram dose in an ITP patient who's relatively small, you could see that. Avatrombopag is our newest thrombopoietin receptor agonist, also oral. It was more recently approved for ITP just a few years ago. It does not have the dietary restrictions or some of the other hepatotoxicity or iron chelator concerns that eltrombopag does, which makes it convenient in that way. But it does not have the longer-term data that eltrombopag and remiplastim both have, right? And we look at longer-term data in terms of the potential risk for bone marrow fibrosis and the potential risk for leukemogenesis and longer-term risks of venous thromboembolism. These are all things that are relevant and important. We expect that avatrombopag probably will not have emergent toxicity long term, like the other two do not have. In other words, we know that remiplastim and eltrombopag are not leukemogenic. They do not increase the risk of irreversible bone marrow fibrosis, things like this. They're safe in the long term, and I'll show you some data for that. But avatrombopag is newer, so technically we don't have that data for it. Fostamatinib, I briefly want to mention. Fostamatinib is a spleen tyrosine kinase inhibitor. It's the newest approved agent for ITP. It's oral. This agent was evaluated in clinical trials with highly pretreated patients, unlike those TPO-RAs I mentioned earlier, which were evaluated in trials of more second, third line type patients. Fostamatinib, the median number of prior treatments was 4 to 5 in these studies, FIT1 and FIT2. So this was a more heavily pretreated population. And in these patients, the primary endpoint of a durable response was achieved in 18% of patients receiving fostamatinib versus 2% of patients receiving placebo. There's been some follow-up analyses that suggest that with fostamatinib, if you give it in earlier lines, the response rate is higher, as we would expect. So response rate around 70% in the second line, around 50% in the third line, and so on and so forth. The issue with fostamatinib, that differentiates it from the oral TPORAs and regular routine daily practice is the side effect profile. All right. So fostamatinib typically associated with more side effects. Typically, we see some of these TKI side effects like hypertension, GI upset, can have some LFT abnormalities, can have some diarrhea. These are things that typically resolve after a few months, but they're also not things that we typically see with TPORAs, where most patients tolerate these quite well, except for the occasional headache that will happen in about 5 to 10% of patients receiving a TPORA. So those are things that often push fostamatinib later in the treatment course. But like I said, every patient is different. And if you have a patient that has, let's say, ITP in association with systemic lupus, and they've had multiple blood clots in the past, someone who has known substantial thrombophilia, then you may reach for fostamatinib in lieu of a TPORA earlier on in the patient's treatment. And you're likely to be successful. With long-term fostamatinib data, as with long-term TPORA data, which I'll show you briefly as well, the responses when patients achieve them tends to be quite durable. So if someone responds to this agent, you can expect that response is likely to be maintained.
Just kind of curious how typically patients do adhere to the dietary restrictions. Do they end up taking it first thing in the morning and fasting for a while? What seems to be the best way to approach it?
Yeah, the greatest success I've had has been with people who either have early dinners, and then I tell them, like, they eat dinner at 5 or 6 o'clock, and then they don't go to bed until 11 o'clock, and I tell them to take it right before bed. It's difficult with the morning because a lot of people will eat something in the morning, but a lot of people wake up in the middle of the night routinely, for one reason or another, to go to the bathroom or whatever. And for those folks, they can keep the medicine by their bed and they just take it when they wake up. It's actually very, very consistent with a lot of folks. There are some folks who do intermittent fasting or who don't eat breakfast, and for those folks, taking it in the morning is acceptable. It's just, a lot of people eat breakfast, and typical American breakfasts have a lot of the things you cannot have when you take eltrombopag. I think the issue with eltrombopag and the dietary restrictions is that a lot of people can do this for a few months or 6 months or a year, but if someone's on this for years and years, oftentimes dietary habits change and things can fall by the wayside. So the first thing I check if somebody seems to have lost their response on eltrombopag is whether they're adhering to the dietary restrictions still. Oftentimes they have grown lax.
And just to be clear, though, they need to fast, like how long before they take it? Do they need to have not eaten, and how long after?
It's 2 to 3 hours before and 2 to 3 hours after. Really,
Right.
most
Okay.
people who have normal gastric emptying will be fine with 2 hours before and 2 hours after. If somebody has, a history of diabetes and possibly some, gastroparesis, then you err on the longer end. And most patients do just fine with 2 hours before and 2 hours after.
Interesting.
So, we have long-term data for imiplastim and eltrombopag, as I mentioned before, which I'm happy to share here. In long-term treatment with imiplastim, the platelet response in those people who achieved it was generally quite durable. We often see this. There are patients who have, overall worsening of disease that will lose a response, and these patients tend to be very difficult to treat down the line, and we need to think about novel agents in them. But, when patients are on a stable imiplastim dose, they typically do well, and they have low rates of bleeding and low need for rescue with steroids or IVIG. Same thing is true for eltrombopag. So this data shows the median platelet counts over, 2 years of continuous response in patients receiving eltrombopag. Again, very large study, lots of patients. When people respond, those responses tend to be durable. Those people who lose their response often have more challenging disease and will have difficulty getting a response with any other agents. And we can, but we have to think about different mechanisms of action in many cases. This is more data from the EXTEND study, which again was long-term use of L-trombopag in patients with chronic and persistent ITP. This shows the incidence of bleeding, and we see that over time, the percent of patients that have bleeding was, again, considerably lower than it was at baseline. It's quite good at controlling patients' bleeding. Any thrombopoietin receptor agonist, when it's maintaining the platelet count, these patients don't typically bleed. When we look at adverse events, we can see, there is that cataracts there, which, that has been a sort of concern with chronic L-trombopag treatment. It's something that we do keep in the back of our mind, we do think about, but it's very, very rare. It does not happen very often, even with very long treatment durations in L-trombopag. And remember that cataracts are common in general, right? So they form in people who are not on L-trombopag too, and are relatively common. But most of the other toxicities here were quite low, including actually LFT abnormalities in patients who have gotten beyond that initial couple years of treatment with L-trombopag. They're just a lot less likely to have emergent LFT abnormalities. They haven't had it early on. Again, this just showing more results of long-term treatment in terms of AEs, acceptable rates of thromboembolism. Recognize that thromboembolism is increased in ITP irrespective of what treatment the patient is receiving, which may sound counterintuitive, but these patients have it's both a bleeding disorder and a clotting disorder. These some more serious complications, very, very, very rare, things like stroke and such. So this just illustrates graphically what I mentioned before, which is that the probability of developing any kind of liver abnormality on L-trombopag drops off as the patient is on it for a longer period of time. It's really highest in that first year and then eventually drops off. So you don't have to monitor LFTs forever in these patients. Monitoring them in the first couple of years of treatment is reasonable. So in terms of switching gears to avatrombopag, right, our newest TPORA on the block, this shows results from the phase 3 study that resulted in avatrombopag's FDA approval for ITP, and just showing that nobody did well on placebo, and quite a large percentage of patients did well on avatrombopag, with a median and mean cumulative number of weeks of platelet response in this 6 month study of about 3 months versus essentially 0 for placebo. The reality is that the response rates to pretty much all of these TPORAs are relatively similar in the 60 to 80% range in the second and third lines.
Just a quick question, because I'm not sure I've seen a phase 3 trial with 50 patients in it.
Yeah, it's a smaller study. Avatrombopag was already FDA approved for a peri-procedural thrombocytopenia in patients with chronic liver disease at the time of the additional approval in ITP, and there's a long-term data with other TPORAs. So my understanding is that it did not require the sort of threshold of data that was required for L-trombopag and romiplostim. And for L-trombopag and romiplostim, ITP was the first FDA approval. So this was a label extension for avatrombopag.
Interesting.
So we can think about clinical trials of novel agents. And ITP, I want to remind everybody, has a complex pathophysiology, including many potential therapeutic targets. So we think about reducing platelet destruction with things like steroids and IVIG and rituximab, and we think about improving platelet production with things like thrombopoietin receptor agonists. But there are more things that we can do, and more potential avenues to disrupt the autoimmune response that perhaps are not currently taken advantage of by current therapeutics. And I'm going to go through some newer therapeutics that are in the pipeline to discuss that. So the first I'm going to talk about is a neonatal FC receptor antagonist. All right, what is the neonatal FC receptor? It has a little bit of a misleading name. It's present in everybody, not just neonates. This is a very important receptor for a number of reasons, but most critically in discussion of ITP, for the recycling of IgG. So the neonatal FC receptor is responsible for the IgG half-life that we have normally of about 21 days. When you block the neonatal FC receptor, that half-life of IgG drops to 7 days. And that's true for pathologic platelet autoantibodies as well as your standard physiologic protective antibodies. So if we block the neonatal FC receptor, we can drop the titer of platelet autoantibodies rather dramatically in ITP. And that's exactly what efgartigimod, which is a new neonatal FC receptor antagonist, does. And efgartigimod is already FDA approved for myasthenia gravis, generalized myasthenia gravis, another humoral autoimmune disease, but certainly has shown promise in ITP as well. This figure is from a phase 2 study of various dosing levels of efgartigimod and placebo. And when we look at higher thresholds of judging a response here, just a platelet count greater than 50,000 once, and then a platelet count greater than 50,000 twice, and then for 10 consecutive days, we see that efgartigimod clearly outperforms placebo here, about 50% of patients having a response to efgartigimod. There was a phase 3 study of efgartigimod that was actually presented as a plenary abstract presentation at ASH in 2022, which demonstrated that in patients who are rather heavily pretreated, again, similar to that fostamatinib data, because nowadays patients have many treatment options before they pursue clinical trials in ITP, and heavily pretreated patients, the response to efgartigimod was substantially greater than the response to placebo, demonstrating the efficacy of this agent in ITP. Patients in this study were receiving efgartigimod IV once weekly, and some were spaced out to twice weekly if they had responded well to efgartigimod initially. Efgartigimod is formulated for both IV and subcutaneous administration, and the subcutaneous study in ITP is currently ongoing. Obviously, we would want to be able to give this drug subcutaneously rather than IV. We look at what happens to the IgG levels over time, the mean percent change. Patients receiving efgartigimod, their IgG levels drop like a rock by about 60% and are maintained there. And patients receiving placebo have no significant change. Then when we look at the endpoints, the primary endpoint, proportion with sustained platelet count response, 22% in the efgartigimod arm versus 5% in the placebo arm. When we look at this according to International Working Group platelet response criteria, which was another secondary endpoint in this study, it's 51% versus 20%. So it's all depends on how you define response, but efgartigimod clearly outperformed placebo, and with most of the secondary endpoints also achieved statistical significance and improvement over placebo. When we talk about number of weeks of disease control, sustained platelet count response, basically however you cut it. There was no difference in bleeding, but that was the patients with efgartigimod did have a numerically lower rate of bleeding than patients with placebo. And this is a rare event. And the study is not powered specifically for bleeding, but powered specifically for platelet count response.
Any, I don't know, infectious complications or other issues that happen in these patients?
That's a great question. So the most common adverse event to efgartigimod is headache. Most of the adverse events are they're low grade and resolved relatively quickly. There was not a significant increase in infection rates in patients receiving efgartigimod versus placebo in this randomized study. This question comes up all the time because we're dropping patients' IgG levels, including their physiologic IgG. It likely there is a Goldilocks zone here where we're reducing the pathologic antibodies enough to have a difference in the disease, but not reducing the physiologic antibodies enough to increase infection risks substantially.
How about response to vaccines?
Yeah, so this also comes up, right? So any IgG antibody is going to be reduced by 60%. So that includes the antibodies obtained in response to a vaccination, in theory, right? So we don't have data that very specifically looks at, titers, in response to pneumococcal vaccination or COVID vaccination or what have you. But nevertheless, in the clinical data, we're not seeing increased rates of infection in patients receiving efgartigimod, even nuisance infections, viruses, and things like that. And the same thing is true in the generalized myasthenia gravis data, as per my understanding. So I think it's a major concern and an excellent question. Obviously, vaccination provokes cell-mediated immunity in addition to humoral immunity, and that cell-mediated immunity is not impacted by efgartigimod, and perhaps that is one of the things that's keeping our patients safe.
Just out of curiosity, has it been looked at in other autoimmune conditions?
That's a great question. So with this mechanism of action, it could be potentially useful in other disorders. And as of this time, it's generalized myasthenia gravis and ITP, but in theory, right, it could be looked at in a number of humoral autoimmune diseases. There also was interest in autoimmune hemolytic anemia, for example, with efgartigimod. You could imagine in other diseases in hematology that are mediated by antibodies, say, for example, antiphospholipid antibody syndrome. I would be really interested to see how this drug could work in patients who have APLS. Which is very dependent on the titer of the antibodies, right, for how severe the disease is. So, it's a great question, and, time will tell if those studies get done. So to move on to another investigational agent. The question of BTK inhibition, given how incredibly paradigm changing these drugs have been in B-cell malignancies, the potential for BTK inhibition in autoimmunity is something that is of high interest. And we recognize that patients who have secondary ITP to their CLL often go into remission of their ITP when treated with ibrutinib. There's published data for this. And so, are we controlling the CLL? Sure, and that can certainly control the ITP, but are we also treating the ITP specifically? And so BTK inhibition has multiple effects on the immune system, of which there are several important in ITP, in particular, their impact on B cells, plasma cells, monocytes, and macrophages. So the question of BTK inhibition in ITP is currently being addressed in a big way. So there's a new investigational agent called rilzabrutinib. Rilzabrutinib is a BTK inhibitor that is being developed specifically for ITP and for autoimmunity rather than B-cell malignancies. And you might say, but wait a minute, BTK inhibitors poison platelets, they reduce platelet function, and they increase bleeding risk. How can I give a BTK inhibitor to a patient with ITP? Well, I'll show you. There was a phase 1b study that was published looking at rilzabrutinib and ITP, published last year in the New England Journal of Medicine, which these patients were, by definition, in the eligibility criteria, refractory patients. They had been through many prior treatment options. They had no acceptable treatment options available to them. So this is a heavily pretreated population. And in those patients, we see substantial improvements in the cohort in their platelet count, which you can see starts at about 15,000. And then the median platelet count improves rather substantially to this, above 30,000 number, which is really quite important in prevention of bleeding. In those patients who were started on the highest doses with dose escalation study of 400 milligrams twice daily, they had even more rapid responses, and a higher rate of those patients responded. And overall, 40% of patients responded to rilzabrutinib. And it didn't matter really how you slice and dice the patients. Patients who had longer disease duration, a similar rate of response. Patients, who are treated with, more prior therapies versus relatively fewer. No patients were early here, but relatively fewer prior therapies, no difference in response. Post-splenectomy versus not post-splenectomy, no difference, no real difference in the rate of response. Concomitant ITP therapy versus not, no real difference. So, this drug, and coming at things from a completely different angle, seems to be able to ignore some of the known risk factors for non-response to things like rituximab, splenectomy, thrombopoietin receptor agonists, which is very promising for it. Now, but what about that platelet function issue, right? So ibrutinib is less targeted, less clean of a tyrosine kinase inhibitor than rilzabrutinib is. Rilzabrutinib, also called PRN1008, with far more kinases inhibited, over 90%. Only 6 with rilzabrutinib, 21 for ibrutinib. And when we look at platelet function assays, light transmission platelet aggregometry in these patients, we can see that patients, healthy volunteers or ITP patients receiving, healthy volunteers receiving ibrutinib, they had substantial reductions in their platelet function. We look at healthy volunteers and ITP patients receiving rilzabrutinib, we see no impact on the platelet function. And so this drug, through differences in how it works at the molecular level, it does not, and inhibiting fewer kinases in the patient's platelets does not reduce platelet function. Very important when you're treating ITP. All right, I'm going to finish off with another novel agent called ianalumab. Ianalumab is an antibody with a dual mechanism of action in being a BAFF inhibitor, which is the B cell activating factor, and being anti-CD20. All right, so this will deplete your B cells like rituximab, but also modify your immune response like dedicated BAFF inhibitors do. For example, belimumab, which is approved to treat systemic lupus erythematosus. There actually was data from the French group looking at belimumab plus rituximab and ITP, and finding rather high rates of durable response. And so that paradigm of combining these mechanisms of action is potentially promising in ITP. Ianalumab is currently being evaluated in 2 phase 3 studies, evaluating this in patients who have a first-line ITP and giving the drug in addition to steroids, and who have second-line treatment where they have failed initial first-line treatment and they're given ianalumab in addition to L-trombopag versus L-trombopag alone. That's how the study is designed. So even patients who are on placebo ianalumab still get L-trombopag. So the whole purpose of this is to change the paradigm in ITP treatment, to induce sustained long-term responses off treatment early on in the course of the disease. By administering an agent like this, which is truly immunomodulatory, can we spare patients from developing persistent and ultimately chronic ITP? And that's the goal of these studies. VAHIT-2 is in the second-line setting with L-trombopag, and VAHIT-1 is ianalumab versus placebo in addition to corticosteroids. So everybody gets corticosteroids in the first line, and there are it's a 1-to-1-to-1 randomization, and 2 out of the 3 groups get varying doses of ianalumab. Right, so these are both phase 3 studies that are looking at it from a different angle, from the beginning as opposed to the end. When we talk about ITP management, most clinical trials are looking at those refractory patients and patients who have failed multiple things. This is taking a different approach. All right, so that concludes my slides, and I'm obviously very happy to discuss.
Just to follow up on that last agent, sounds really interesting. I was starting to think it was a bispecific, but I guess it's not. It's like it's only one antibody?
Correct. It's not a bispecific antibody. It's one antibody, but it has a dual action.
And any tolerability toxicity issues other than what you were talking about?
It's a great question. These are the first studies in ITP. There have been studies of ianalumab published in other disorders. I believe there was a study in Sjogren's syndrome, actually, that was recently published. This is an agent that's being looked at in multiple autoimmune diseases. In terms of stereotyped toxicity, none that I'm specifically aware of, just the sort of long list of AEs that are collected. There is a potential for an infusion reaction with ianalumab, which has to be, you have to administer carefully, often give with corticosteroid pretreatment. But in terms of longer term, it's sort of like the rituximab story. Patients don't typically have sort of, nuisance toxicities that are ascribed to the agent. It's more, what are the sort of longer term immune complications of using an immunomodulatory drug, which we're learning, obviously, with this newer drug.